In this last lecture, we're going to be talking about the care of the client with cerebral vascular disorders. We're going to be talking a lot about stroke. When you're thinking about clients, excuse me, that are undergoing a stroke, I want you to think of it as a brain attack. A lot of times we talk about myocardial infarctions as a heart attack. A stroke's going to be the same thing. It's going to be an attack on the brain. And because we're talking about a brain attack, we want to intervene early to help maintain that brain tissue. This is also called a CVA, or cerebral vascular accident. When this occurs, there's a disruption in arterial cerebral flow, and that is secondary to either ischemia, hemorrhage, or embolism. This is a medical emergency in which neurodeficits result from a sudden decrease in blood flow to a localized area of the brain. When it occurs by ischemia, that is when the blood supply to a part of the brain is suddenly interrupted by a clot or vessel stenosis. If it's hemorrhagic, that's a bleed from a rupture, and that is spilling blood into spaces surrounding the neurons. Residual effects are going to vary and are typically dependent on the area of the brain involved. You have to also think about the size of the affected area and the length of time blood flow is decreased or stopped. When a stroke occurs, an ischemic cascade or a chemical reaction occurs due to cellular changes, and this is going to happen in 3 phases. Primary cell death begins as blood supply is cut off, creating ischemia or necrotic cells. This begins within 4 to 5 minutes and can last for 2 to 3 hours. With secondary cell death, the cells surrounding the area of initial damage are exposed to excessive cell excretion from the necrotic cells. These affected blood cells have enough blood supply to live for a few hours. This means if we're able to restore blood flow, some cells can survive and become functional. The body will do further cell damage through an inflammatory reaction, making it more difficult for the body to dissolve the clot. So when we're talking about a brain attack, we want to focus on early intervention. I want you to review this. It is critical to understanding how a stroke affects a patient by where it is occurring. So different locations in the brain are going to have different effects with a stroke. The anterior part of the brain is supplied with blood from the 2 internal carotid arteries. The posterior portion of the brain is supplied from blood flow within the vertebral arteries that come together to form basilar arteries that supply the brainstem and the cerebellum. These major arteries are connected to form a circle of blood vessels known as the circle of Willis. The circle of Willis provides alternative routes for brain tissue to receive their blood supply. Some risk factors for stroke. Age is going to be a big one. Risk for stroke doubles for every decade over the age of 55. And 2/3 of all strokes occur to people over the age of 65. More males are going to be affected than female. In ethnicity, African Americans are twice as likely to have a stroke, and that's due to hypertension. Family history can also be an issue. Think about how family history relates to hypertension and other diseases like diabetes that are going to increase your risk factor. Also, previous CVA. Patients that have already had a CVA are more likely to have a second one. Lots of comorbidities here are going to increase the chances of a client having a stroke. So hypertension, heart disease, diabetes, and in regards to diabetes, individuals with diabetes mellitus are going to fare a lot worse after having a stroke. Sickle cell disease, the RBCs have a procoagulant that's going to be promoting coagulation, and that activity promotes cell adhesion, increasing the opportunity for thrombus formation. So these patients here are going to be at an increased risk. Atherosclerosis, hyperlipidemia, AFib, infections, and of course, again, previous stroke or TIA. Sleep apnea is a big issue with strokes. So a recent study from Mayo found that a cardioembolic stroke is far more common with patients in obstructive sleep apnea than patients without. I just want you to keep that in mind when we're talking about risk for stroke, because obstructive sleep apnea can really make hypertension worse. And when the neurologists are coming in to talk to these patients after they've had a stroke, a lot of times they will screen them for obstructive sleep apnea. So substance abuse does decrease cerebral blood flow, and the one that's going to be most notorious for this is going to be cocaine. So when these patients come in that are young, that are, you know, in their 20s or 30s, that have had a stroke, a lot of times they will do substance abuse screening because that's just an atypical age to be having a stroke. Obesity, that ties in within a lot of things, definitely ties in with sleep apnea, and what we talked about on the previous slide is sleep apnea putting a patient at an increased risk for stroke. Sedentary lifestyle fits together again with the obesity and the sleep apnea, and of course smoking. Smoking almost seems to be one for everything. Almost. Those of you who plan on practicing in other states, I just want you to take a look at this because they call this the stroke belt. So this is the region in the southeastern United States that has the highest incidence of strokes. And even though this was identified in 1962, it is still an ongoing issue with 10% above average for people with stroke. This is going to be really related to high rates of hypertension, low socioeconomic status, poor quality of healthcare facilities, increased incidences of smoking and infection. And think about the diet that's high in fat in that area. Even though men are at higher risk for stroke, there are some risk factors that are going to be particular to women that are going to increase the chance. So strokes during pregnancy and childbirth are on the rise due to a population of pregnant women that have higher risk factors for stroke compared to about 10 years ago. Think about obesity, increased blood pressure, inactivity, and diabetes. So we have higher risk factors with our pregnant population than we did 10 years ago. Menopause, that's due to lack of estrogen. Estrogen has a protective effect for cardiovascular and for strokes. Patients with migraines. So migraine with aura, that's a migraine that is preceded or accompanied by a variety of sensory warnings or symptoms, such as flashes of light, blind spots, or tingling in your hands or face. This is controversial, but some studies have found that individuals that experienced a stroke had a similar association with migraines. And I'm not sure if any of you suffer from migraines. I do since about the age of 17, and sometimes during a migraine it makes me feel like I'm having a stroke. So some of the symptoms can be similar. Autoimmune disorders, think about your diabetes and your lupus. There's going to be an inflammation to the blood vessels with those disorders. And then clotting disorders. So if their blood clots too much, they're going to have ischemia, or if it doesn't clot enough and they have bleeding problems, they could suffer from a hemorrhagic stroke. So the pathology of this, when there's ischemia, this begins within about 45 minutes when blood flow and oxygenation decreases. This is going to result in a necrosis of the cell where severe or prolonged ischemia leads to cellular death. And this is going to be irreversible once this happens. In a stroke, the blood entering the brain compresses adjacent tissues and causes vessel spasms as well as cerebral edema. The blood itself, it can irritate meninges and brain tissue, and that's going to cause an inflammatory response. Onset of manifestations for these is going to be rapid. So ipsilateral, that means the same side. I think of it this way. It has an S in it, so it's the same side. Contralateral is going to be the opposite side. Someone with a right hemi CVA is going to have left-sided deficits. Strokes lead to a loss or impairment of sensory motor functions on the side of the body opposite the side that the brain is damaged. So that's a contralateral effect. This slide, it looks a little bit scary, but I'm going to skip it completely. I'm leaving it in the PowerPoint presentation for those of you that are curious, and I'm going to zoom in on it just a little bit. So what is listed here, are different types of strokes and how it's going to affect the area. So when I'm testing you on these, I'm not going to be testing you on, oh, are they going to have a stroke in the pons and what kind of effects is that going to be? No, that's not going to happen. This is good information to know, especially if you plan on being a neuro nurse someday, but this is not going to be expected at your level, so we'll just skip it. We're going to talk first about general manifestations of stroke. This means that they're going to apply to all types of strokes. These are some terms that I would like for you to know. And patients can have different combinations of these with different types of strokes. So I really want you to look these up so that you understand them a little bit better. I will mention about these two types of aphasia here. So the Broca's aphasia, sometimes we refer to this one as expressive aphasia, and the Wernicke's, we sometimes refer to that as receptive. So you might see textbooks refer to it either way. Weakness is going to be the most common manifestation of stroke, and that is going to involve the face, arm, and sometimes the leg, depending on the severity of the stroke. They could have numbness on one side, a loss of vision, and that can be partial or complete. Speech difficulties, think about these areas of aphasia we talked about. Sudden and severe headache. These patients will describe this as the worst headache they've ever had in their life. And then difficulty with balance. Sometimes these patients, when the stroke occurs, they will fall. So here's some signs of a stroke. We as healthcare professionals are trying to educate the public on using the term fast, because when a stroke occurs, we want to act fast to preserve the brain. So warning signs of a stroke, if you're going by the term fast, you're going to look at their face. Ask the person to smile. Do they have a facial droop? In the hospital, sometimes when we're assessing for a stroke, sometimes the patient will say, well, I don't want to smile. Have them stick out their tongue if that's the case, or raise their eyebrows. Arm, ask them to raise both arms. Do they drift downward? Does one arm go higher than the other? Are they able to not move one arm at all? Speech, ask them to repeat a simple phrase. Do they have a stutter, or do they say strange words, or are they unable to speak at all? And then time. If there's any of these symptoms and you're out in the field with patients in the community, call 911 and act immediately. Treatment's going to be more effective the quicker it is rendered. Every minute counts with a stroke. You'll hear some people say time is tissue, and that means the faster we react, the more we can preserve that brain tissue. These patients are going to have some sensory perceptual deficits. They could also have behavioral changes. Sometimes I will be taking care of a little old lady and she'll start swearing, and her family is mortified because they'll say, well, grandma never talked that way before. So what they're experiencing is some behavioral changes. Intellectual changes. Sometimes they won't be able to do the same type of activities that they were doing prior to their stroke. Disorders in the communication, they may not be able to communicate at all. They might be suffering from a receptive or expressive aphasia, or even a global aphasia. Motor deficits, it always seems like a person has the stroke on their dominant side. That is really quite a deficit that they're going to have after their stroke. And then elimination changes. They might have trouble with their bowel and bladder after they've had a stroke. A stroke may involve pathologic changes in neurologic pathways, altering the patient's ability to integrate, interpret, or attend to sensory data. They can have deficits in vision, hearing, equilibrium, taste, and even sense of smell. Even alterations in vibration, pain, warmth, cold, and pressure. In hemianopia, we've got a loss of half of the visual field in one or both eyes. So with this, and I'm going to show you a picture of it here in a little bit, they can't see half the screen. So if you imagine from here over in both of your eyes not being able to see, you want to teach your patients to scan their surroundings fully, and that's going to help them with eating because they're not going to see half their plate. It's going to help them with walking. We don't want them to fall. And we really are focusing on a prevention of injury here. Agnosia, this is when they're going to be unable to identify familiar objects. When we're testing for this, a lot of times we'll show them everyday objects like a clock, or we'll even ask them to draw something, and they're not able to do so. Apraxia, that's an inability to perform purposeful movements such as getting dressed, brushing your teeth, or even feeding themselves. Neglect syndrome. Neglect syndrome is a disorder of attention. They're going to ignore the affected side, and this is going to be most often seen after a large area of damage occurs. And that generally is going to be in the right parietal lobe. This is a frequent consequence of a stroke on the right side of the brain, and thus the patient ends up neglecting everything on the left side. This is not going to be blindness. Patients can see and recognize and name items. They just will ignore them. And you'll see this happen when the physician is testing them. They'll wiggle their finger, the physician will wiggle their finger, and the patient can see it, but the patient is oblivious. Sometimes I've seen the patient themselves feel like that side of their body belongs to somebody else. When they do testing for this, they'll tell the patient, go ahead and draw a clock, and what will happen is they will draw the right side of the clock, but not the left. With this type of neglect, they're going to be bumping into objects on the left-hand side if that's where their neglect is. They will like brush their teeth, but they won't brush the left side of their mouth. And what's going on is the brain has the information, but the patient does not have any conscious awareness of that side of their body. And a change in consciousness, that has a very wide range. It can be mild confusion, family saying the patient's not quite themselves, all the way to a coma. So here's what I was talking about with the hemianopia. So half the visual field is lost. This can be in one or both eyes. Most of the patients I've taken care of with this, it's in both eyes. So they have half their visual field lost in each eye or even one. This is going to be the agnosia. So the patient is not able to identify a familiar object. They cannot say it's a lock. They're going to say something else. This is different than expressive aphasia, where the patient knows what they're looking at, they just can't get the word out. And they can have a combination of the two as well. For behavioral changes, we've got emotional liability, and that is going to be when the patient laughs or cries inappropriately. Sometimes with these patients, they'll be generally a happy person, and you'll come in the room and they'll be crying, and you'll ask them what's going on, and they don't know. So they might even say, I'm not sure why I'm crying. Loss of self-control sometimes goes back to that little grandma I was talking about earlier, where they have excessive swearing for people that have never really sworn in their life, or even refusing to cooperate. Like they will refuse to get dressed, they'll refuse to use their call light, they're super impulsive, so they have a loss of self-control. Decreased tolerance for stress, so they've got a lot of anger or depression. They really can't handle change. A lot of behavioral issues can go along with strokes. Memory loss, if they do have some memory loss, like if they're not able to recognize their family, a lot of times I'll ask the family to bring in pictures, and we'll make them a memory book. That way it'll have a picture of their daughter with their name underneath it. So there's some things that you're able to do for these issues. Decreased attention span, think about ADHD times 10. A lot of times they can't focus for more than a few minutes on a task. Poor judgment, that goes back to impulsive behavior. They may not rationally think, I need help to get up, I can't move the left side of my body. They might just try to get up anyway. Inability to think abstractedly. So thinking characterized by the ability to use concepts and to make and understand generalizations, such as the properties of a pattern shared by a variety of specific items or events. So they're not going to be able to think that way. So no abstract thinking for these individuals. And that's if it's affecting that area. And all of these deficits that I'm talking about are really going to depend on the area of the brain involved. Hemiplegia, that's going to be paralysis on either the left or the right side. And hemiparesis, that's going to be a weakness of either on the left or right side. And sometimes you'll see complete flaccid limbs, so like the whole left side will not move. And sometimes as they're starting to recover from their stroke, they might be having some spasticity. A lot of times family will get really excited when this happens, and they think that, you know, grandma's making some strides and getting some function back. That might be possible, but it might also be some spasticity that's occurring. So when you're looking at this photo here, I want you to pay attention to a couple different factors. What's going on here? Is this patient able to move their left side? So they've got hemiplegia, and originally when I found this photo, it said it was only affected in the left arm. But if you look here, this person has an orthotic on. So it's possible that they have some hemiplegia on the whole side, or they might have hemiplegia up here on the left arm with hemiparesis, so partial movement on that left leg, so where they're dragging the leg. But really this orthotic can be used with both of those. So this goes up from the thigh, so it'd be a thigh, knee, ankle, foot orthotic, and that's going to help stabilize that leg. Ischemic strokes are going to be the most common types, and that accounts for about 87% of all strokes. They can be caused by clots, narrowed vessels, thrombosis, or embolisms. In a thrombotic stroke, blood flow is going to be impaired due to a blockage of one or more of the arteries supplying the brain. The clots are formed within these larger vessels due to bifurcations and atherosclerotic plaque development. An embolic stroke, like the one we see here, is going to be a blood clot from somewhere else in the body that travels to the brain. So think about blood clots in the legs. Those generally go to the lung, but sometimes we can have a clot that goes to the brain that was developed in an extremity. And this is an example of one that's a hemorrhagic. So we see a blood vessel that has ruptured in this area, and there's blood in the surrounding tissues. This type is going to be the most fatal type. With an ischemic stroke, there is a lack or a complete stop of blood flow. So we see here in both of these types of ischemic strokes, this atherosclerotic clot and this blood clot are completely occluding blood flow to this area. So that section of the brain is completely cut off. This is going to ultimately cause brain infarction. So this tissue could die, depending on how long that ischemia is lasting. And again, this can occur from blockage, like the blood clot or the atherosclerotic clot, or from stenosis. These can be classified as transient, thrombotic, or embolic. A transient ischemic attack, or a TIA, is going to be an episode of neurologic dysfunction caused by ischemia or decreased blood flow, but no infarction or tissue death occurs. This neurological effect typically lasts less than 24 hours. Be aware, however, that a TIA is typically a warning sign for an ischemic thrombotic stroke. So we really want to pay attention to those TIAs. Thrombotic strokes are going to be caused by an occlusion of a large cerebral vessel by a thrombus. And these can be due to atherosclerosis or trauma to the vessel. They most often occur in older people who are sleeping or resting. And that is because blood pressure is going to be lowered during sleep, so there's less pressure to push the blood through an already narrowed artery. These tend to occur in arteries that are going to bifurcate. They occur rapidly, but progress slowly and continue to worsen over 1 to 2 days. For an embolic stroke, that's going to occur when a blood clot or a clump of matter that is traveling through a cerebral blood vessel becomes lodged in the vessel. Onset for this is going to be sudden. They're going to have immediate effects. These can be from AFib, ventricular thrombi, an MI, CHF, and anything that's going to predispose your patient to blood clots. A hemorrhagic is just like it sounds. So the blood vessel ruptures. We see this rupture here, and blood leaks into brain tissue. So we've got a twofold problem here with not enough blood getting to these areas, and then this blood that it's going to accumulate and put pressure on this part of the brain. So we have an intracranial hemorrhage. This is most often going to occur with patients that have sustained hypertension, and that is going to be the leading cause. The contributing factors include hypertension, rupture of brittled arterial walls, and that can be due to plaque, ruptured aneurysms, trauma, anticoagulant therapy. So examples of this could be your patient that is on Coumadin that falls and hits his head. Whenever I see somebody fall in public and they hit their head and I go to help them, one of the first things I ask them is, are you on any blood thinners? And if they say no, I say even aspirin or Plavix. So that's just always important information to know. And again, these types, the hemorrhagic type, is going to be often the most lethal. And I really want you to focus on the causes of this, because hypertension is going to be the big heavy hitter with hemorrhagic strokes. Manifestations for a hemorrhagic stroke: these patients are going to have a headache, and that's due to bleeding with an oxygen deficit. They might have some vomiting and seizures, and that's due to meningeal irritation. All of this blood is going into that space where it doesn't belong. They're going to have progressive neurological deficits, hemiplegia, loss of consciousness, and if it's the brainstem, it's going to affect their respirations. Pressure and edema can cause increased ICP, and that's going to result in coma and death. With patients with right-sided cerebral hemisphere strokes, this is going to involve a loss of visual and spatial awareness. So think about proprioception. And proprioception is going to be awareness of oneself in space. So when you're assessing for this, you would have the patient close their eyes. You would touch the non-affected side, so their right side's going to be non-affected. You could even move their foot up or down and ask them if it's pointing up or down. And if they have issues with proprioception, they're not going to be able to tell you. with a left-sided hemisphere, that is going to involve language, analytical thinking, and mathematics. A lot of times these types of patients are going to be very impulsive. So if your patient does have a stroke with right-sided arm and leg paralysis, what else would you assess? You're going to look for their language and their ability to follow commands. So just know that what we see on the right side versus what we see on the left side could be two totally different effects. Before we go too far into diagnostics, I want to throw an example out to you. So your CNA or the physical therapist calls you into the room and says the patient's not acting right. They've got slurred speech. They're really not following commands. Before you do anything else, if you're suspecting a stroke, I want you to take their blood sugar. A lot of times with these patients in general, and one of the first things they do on the stroke protocol is take a blood sugar. Hypoglycemia sometimes has the same manifestations, especially with patients that have already had a stroke. So make sure you're checking their blood sugar first. So with these patients, you want a thorough history and physical findings, including a neurological exam. Diagnostic imaging, so you're immediately going to be taking a CT, and you're going to be doing this without contrast on these patients. Ischemic strokes will not show up on a CT until about 6 to 8 hours after a stroke, but a hemorrhagic stroke is going to be seen immediately. So a CT must be done first due to time factors for TPA, and that should be done in about 20 minutes is what Methodist shoots for. So Unity Point shoots for about 20 minutes. They could also do an MRI, but initially in that first phase, they're going to be doing a CT. A lumbar puncture, that's to obtain cerebral spinal fluid. And with an ischemic stroke, they may elevate CSF pressure, and a hemorrhagic stroke may be seen in CSF. Plaque testing, that's a blood test that's going to measure the levels of a lipoprotein involved in endothelial dysfunction, and that leads to atherosclerotic plaque formation and possible rupture, which can block a blood vessel. So that's going to be a screening tool. And then the NIHSS, that's going to be a stroke scale, and I'll show you a slide on that on the next screen. And that is used to assess neuro outcomes and recovery. The cerebral angiogram, that can also be done to coil brain aneurysms. And we see on this scan right here, this is a hemorrhagic. All that area right there is blood. This is going to be your NIST scale. This is a clinical evaluation tool, and it's used to measure the outcome and degree of recovery. This is done initially in the ED, 2 hours post-treatment, and at 24 hours and at the time of discharge. So they're going to do it several times, and it's a good measurement of how a patient improves over time. I'll make sure to post a video about this too, so that way you can see a NIST scale in action. These are performed by special nurses that have certification in this area, so not all of you will undergo training for this. Glucose, again, very important. A blood sugar is going to help differentiate between signs of hypoglycemia from stroke manifestations. So you're going to be doing this first. And then a CT is needed to guide treatment, but it takes about 24 hours for necrotic tissue to show on a CT. And again, a bleed will show right away. Treatment, we really want to focus on prevention as always. So encourage your patient to stop smoking, go into drug rehab if it's cocaine is an issue, lose weight, eat healthy, lower cholesterol, control diabetes, treat infections, and CPAPs. If they have sleep apnea and they've been screened positive for it, encourage them to wear their CPAPs, and encourage public awareness of signs of stroke. So teach that FAST again. Most of the times, the healthcare professional is not going to be around when these type of things occur, so we want public education. Acute care, that's required after stroke. We're going to stabilize the patient and then send them to rehab. Once they're in rehab, they'll undergo PT, OT, and speech, and the goal is to make the patient independent as possible. So even if they still have some effects from the stroke, we want to encourage independence. So we want to take care of these right away. So rapid recognition, rapid reaction, rapid EMS dispatch. We're going to be calling 911 right away. EMS transport, hospital pre-notification. So EMS is going to notify the hospital when they're en route. And rapid diagnosis and treatment. We want to be aware that time is tissue. We don't want these patients to experience any type of loss of tissue. We want to be able to give TPA if the CT shows that it's not a hemorrhagic. So we cannot give TPA for a hemorrhagic stroke. TPA is going to be the clot buster, and that needs to be done as soon as possible, but within 3 hours of onset of symptoms in order for it to be effective. Here's your FAST again that we talked about. So face, again, have the patient smile. If they don't want to smile, have them stick out their tongue or raise their eyebrows. You'll see that the eyebrows will only raise on one side. Arm, are they able to lift both of them? Is one of them flaccid? Are they speaking funny? If they have slurred speech or not making any sense, then you need to call 911 and get treatment as fast as we can. Going by the ABC approach, if your patient is unconscious, airway is going to become an issue. So you want to make sure that you're monitoring their airways. Hypotension will decrease perfusion to an ischemic area. So if they have ischemia, expect the patient to have an extremely high blood pressure. Typically, a goal is to have less than 180 systolic. So again, hypotension or low blood pressure is going to decrease perfusion to an ischemic area. That's going to be for ischemic strokes, not for bleeds. So you want their pressure to be a little bit on the high side to get around that area of ischemia. So like if this area is blocked, you want it to be hypertensive to get around that area. You want to assure adequate oxygenation. So part of the stroke protocol is going to be to put them on 2 liters of oxygen. They may require more, but you want to increase that oxygen to try to decrease any cerebral ischemia. And then assess for possible seizures or diabetes insipidus if the pituitary gland was damaged. For management and treatment, remember your ABCs. Make sure that you're doing your AccuCheck to rule out hypoglycemia. Assess for the stroke mechanism. What was the cause? Was it AFib or hypertension? If it's AFib, we've got an ischemic issue. If it's hypertension, we could have a hemorrhagic issue. Aspirin, we want to make sure that we're not giving that within 24 hours until a follow-up CT scan is done to verify there's no intracranial bleed. And a thrombolytic is only given if it's due to an ischemic stroke. So we're not going to be giving thrombolytics in the case of a hemorrhagic stroke. Speaking of thrombolytics, so the thrombolytic that we would be using would be TPA, which is tissue plasminogen factor. We're going to use that to treat an ischemic stroke, and it's going to dissolve the fibrin that binds the clot together. So it's going to be breaking up that clot and restoring blood flow to that area. We're going to be giving this by IV. So TPA by IV, it is within 3 hours of the onset of symptoms. So they really need to be calling 911 right away. If the patient waits for a couple days before they come in, it's going to be too late to give that TPA. CT, that's going to rule out a bleed. We can't give a thrombolytic if there's a hemorrhagic stroke occurring. And then blood pressure. Blood pressure less than 185 over 110. So that's what we're shooting for with their blood pressure. If it's higher than that, we're going to be given some nitro paste, so nitroglycerin paste, or labetalol IV. You also have to be 18 or older in order to get TPA at this point. That might change once you get to peds, but as for right now, it's 18 and up. Contraindications to the use of thrombolytics. So if your patient's going to be on Coumadin or any other type of anticoagulants, they're not going to be able to take that thrombolytic. History of blood dyscrasia is also very important. Any history of bleeding. So think about your patients that are high risk for bleeds. Major trauma or surgery within 14 days. So if this patient had a knee replacement last week, they're not going to be able to get TPA'd. Pregnant or lactating, we don't want to harm that baby. And arterial puncture within the last 7 days. So if this patient had ABGs 2 days ago, they're not going to be allowed to have thrombolytics. So your responsibility with the use of thrombolytics, first of all, you're going to want to get IV access in before you start any type of thrombolytic therapy. Getting those lines in will help decrease the risk of bleeding. Bleeding precautions, that's going to be for 24 hours after infusion. Watch for signs of stroke. So you're going to monitor their neurostatus. You're going to look for any deterioration of neurological status. And then if it's successful, if the treatment is successful, the patient can become better with little or no deficits. So the earlier we intervene, the better for these patients. Different medications we can give for patients in the long term after a stroke. Just remember that with any type of anticoagulant therapy, things like Coumadin, heparin, Lovenox, even aspirin and Plavix, they're not going to be giving those for about 24 hours after thrombolytic, and they're going to want to do a repeat CT scan to make sure that the patient doesn't have a bleed. If there's some irritation to the brain, they might be giving some anti-seizure medication, some Dilantin, or even some Neurontin to help with that. And any type of aspirin or Plavix for antiplatelets, they're going to be discharged on that medication and taking that long term. Monitor their blood pressure. You want to make sure that it's adequate for cerebral perfusion. You don't want it too low, but you also don't want it too high either. And it's going to be a little bit on the high side for your patients with an ischemic stroke to help maintain cerebral perfusion. You're going to evaluate their swallow. You're going to do a bedside swallow test before giving these patients anything by mouth. If their swallow is really poor, you're going to get speech therapy involved to do an official swallow study with diagnostic screening. These patients sometimes do end up with a tube feed. PT-OT, you're going to get PT involved to assist with returning ambulation, and OT to help with ADLs. So you want balance training, gait training from PT, and OT with ADLs, speech therapy to help with communication and swallowing. DVT prophylaxis, especially if your patient is non-ambulatory. So we want to prevent any further issues by making sure we're using our SCDs and our blood thinners. If there's a fever present, make sure that you're treating that fever and contacting your provider. Safety is going to be a big issue with these patients. If they're impulsive, they need to be on bed alarms. I'm of the mind, I don't want to say I don't trust patients, but they're out of their own environment. They're in a new facility. I keep a bed alarm on all of them for at least 24 hours till I get to know them a little bit better. And that's just a standard for me. And sorry, this means long-term care, so LTC long-term care. And then possibly they might be doing an endarterectomy, and that's to prevent recurrence. And this is a picture of an endarterectomy. So they're going to be making an incision, and this one's in the carotid area, carotid endarterectomy. They're making an incision in the neck, going in through the vein, and they're removing the plaque that caused the issue, and that restores blood flow to the brain. With hemorrhagic, again, we want to support our ABCs. So if your patient is unconscious, we need to be concerned about their airway. For medications, vasospasms can occur to about 30 to 70% of these patients after a hemorrhagic stroke, and that's going to be an emergency. Taking calcium channel blockers will reduce this risk. Amicar, that is an antifibrinolytic. That's going to be used to decrease the chance of rebleeding, but it can also increase the chance of an ischemic stroke. Amicar is going to be used in conjunction with a calcium channel blocker. To treat shifting and edema, mannitol can be given. That's an osmotic diuretic to decrease intracranial pressure in the subarachnoid space. They can also give corticosteroids like dexamethasone. And then stool softeners. I want you to think about why you would want your patients not to be constipated. Because if they're constipated and they're bearing down, they're really going to increase that ICP. For Dilantin, sometimes these patients, it runs between 4 and 28% of patients with intracranial hemorrhage. They could end up having seizures, so we want to make sure that we're intervening early with that. And pain is going to be a common complaint after stroke, so giving analgesics can help with the rehab process. And then lastly, it's not on here, but I really want to stress it to you. If your patient is on a blood thinner and they have a hemorrhagic stroke, you need to reverse it. So if they're on Coumadin, make sure that you're giving vitamin K, FFP. We want to stop them from bleeding more. They can also perform a ventriculostomy, and that is often done in the setting of obstructive hydrocephalus, which is a common complication of a thalamic hemorrhage within the third ventricle compression and of a cerebral hemorrhage within the fourth ventricle compression. Ventriculostomies are associated with high rates of complications, including bacterial meningitis. So this is going to really be a last-ditch effort for these patients. They could also be performing surgical correction with aneurysms. They're going to do a craniotomy with clipping. They're going to do endovascular coiling, and that's an electric current that's passed through a coil, and that causes coagulation. With atriovenous malformations or AV malformations, if the area is accessible, they're going to perform an excision and evacuation of the hematoma. They might also remove the clot with a metallic or gel form pellet, and then radiation or laser therapy to induce coagulation. There is a picture right here with an aneurysm clip for repair. There's your aneurysm, there's the normal vessel, and there's the clip cutting that area off from the vessel. With these patients, rebleeding and vasospasm is going to be a pretty big risk, and that is greatest about 1 day after rupture, and then again at the 7 to 10 day mark when the initial clot breaks down. So you really want to make sure that you're monitoring your patient for any sudden decreasing level of consciousness and any new neurological deficits. Other medications that might be given: antihypertensives if the cause was by hypertension, corticosteroids to use to decrease brain edema, mannitol, hyperosmolar solutions like D5.9, D10, D5LR are going to increase urine excretion. And intravascular infusion of hyperosmolar solutions has really been shown to increase cerebral blood flow, and presumably this is due to a direct vasodilatory effect. So it's going to help dilate those blood vessels. Diuretics are going to be given to decrease blood pressure, and anticonvulsants to decrease any type of seizure activities. Surgery may be performed to prevent occurrences of stroke, and that's going to restore blood flow when a stroke has occurred or to repair vascular damage or malformations. We looked at that picture already of an endarterectomy. That is one option that's going to remove the plaque. Extracranial intracranial bypass is performed when an occluded vessel is not directly accessible to increase or restore blood flow to the brain. This involves connecting a blood vessel from outside the brain to a blood vessel inside the brain. It reroutes blood flow around the artery that is narrowed, blocked, or damaged. This is done by either grafts or donation. Nursing care for these patients is often complex and multidimensional and requires consideration of continuity of care, long-term care, rehab centers, home health, PT, OT, speech therapy, psychotherapy, the list goes on and on. So the possibility of placement in a long-term nursing care facility or assisted living is even possible. And these nursing diagnoses go along with that. So you're going to monitor your patient for ineffective tissue perfusion. We want to make sure that they've had no changes in their deficits. Impaired physical mobility, especially if they're suffering from hemiplegia. Self-care deficit goes along the same lines. That's why we have PT and OT involved in their care. Impaired verbal communication, if they're having expressive, receptive, or even global aphasia. Get speech therapy involved with this. Make these people a memory book. Impaired urinary elimination, sometimes that's an issue post-stroke. Risk for constipation, we don't want that ICP to change. And impaired swallowing. And then we're just going to briefly go over TIAs. So TIA, this is going to be a brief period of localized cerebral ischemia that causes neurological deficits, but they're very short term, so they're not lasting more than 24 hours. Often these are going to be warning signs for a future ischemic or a thrombotic stroke. So we really want to encourage these patients to get treatment. Treatment can be done with antiplatelet agents such as aspirin, Plavix, Persantine, and so on. So these patients are going to be given these to prevent clotting in the future. Symptoms, they're going to be very similar to a stroke. So any type of, think about your FAST, so your facial. So are they able to smile? Are they able to raise their eyebrows? Can they hold their arms up? Do they have flaccidity? Are they flaccid on one side? Just think about all those same types of considerations. Speech, are they having issues with their speech? And we want to act quickly with these patients. So they're going to be very similar to a stroke. And really that's going to be it for TIAs, because everything else about how we would treat them is going to be similar to what we do for a stroke. So I want you to think about a couple of things moving forward. Your patient has a stroke with the right side hemisphere involvement. Objects should be placed on what side? So if they're right side hemisphere involvement, which side of their body is not able to move? In this case, we would have a contralateral effect. So it would be their left side that would not be able to move. So if we're giving them their call-light, what hand or what side would we put that on? We would put it on the right side. Same thing with anything they need to access. So you would put their bedside table on their right side. What type of communication strategies could be used for a client with aphasia? Well, first of all, you need to know what kind of aphasia they're having. Sometimes they'll be able to just tell you whatever is on their mind. Other times they can't, so it just depends on the patient. So if your patient has expressive aphasia, your communication strategies are going to be different for them, the ones that have receptive aphasia. And remember, with receptive aphasia, they're not able to process the information you're telling them. With expressive aphasia, they understand what you're saying, but they are having a hard time communicating back with you. And then think about your possible nursing diagnosis for strokes. And that officially is your very last lecture for this course. As always, if you have any questions, make sure that you reach out to the discussion boards. We like to share information with one another, and you have a great day.